Hello, everyone. We are back again with our topic in ENT. So, before we start, a brief introduction about Auricle. So, Auricle is a platform where we train students for their academics and for their next exam or for the university exams and all. So today's topic will be trauma to the face and anatomy and physiology of paranasal sinuses. So we'll cover anything that comes around these chapters. These are the questions that you see on the screen that will be important, and you can expect these questions from these chapters. So Auricle, we have recorded classes, live classes, we have practical sessions, hard copy books, it's an exam modules. Every module has its own perk. Recorded classes can be seen and viewed anytime. Live classes, you will have one-on-one live classes. Practical sessions will prepare you for your practical exam. Exam modules we have, and we have hard copy books. It's for anyone who cannot cope up with the textbooks. So we have foundational classes where we have flexible learning done by expert instructors, and in the end we do a convenient revision. Live classes, of course, like we have now, which will be live. Anyone who wants to join it can join it and make the use of this class. Express exam module. It's an examination module designed to cover the entire syllabus in 20 hours. It is like a revision before you, appear for the exam. So once you're thorough with every topic, you can use Express exam module to, have a thorough revision before you go to the exam. Now, one-to-one doubt clearing sessions is for those students who have certain doubts in certain topics and they are unclear about it. Hard copy note sets. We have notes written by experts or in such a way that if you use it, you can learn how to express, how do you, present the answer sheet in the exam. Okay, so we use previous year's question papers to create questions in those. We have question bank also, which you can download in your Android or Apple phones. This is most useful for academics in NEET, PGs, and FMGs. We prepare students for practical exams as well. What you see on our screens are subscription plan, anything that you want, and you can use the QR code mentioned below. Okay, all right. Now let's start. So today's topic, let's start from acute frontal sinusitis. Now, acute frontal sinusitis can be asked for a 4-mark question, and you have to present it as etiology, clinical features, treatment. Treatment is divided into 2 sets, medical, surgical. Okay, so etiology, if you see it on your screen, it is usually followed by viral infections of upper respiratory tract. Later on, after viral infections, it is followed by bacterial invasion. First, it occurs because of viral infection followed by bacterial invasion. Second, it usually seen in the swimmers. So entry of the water in the sinuses during diving or swimming can lead to acute frontal sinus. So where is exactly the frontal sinus? Yeah. Frontal sinus. Okay. The inflammation of frontal sinus is known as sinusitis. Frontal sinusitis. Or due to some external trauma, due to sinus infections like fractures or penetrating injuries, punches, anything. Or if there is an edema of the middle meatus. I hope everyone by now knows what I mean by middle meatus. Where do you see it? Which part of the nose it belongs to? And which openings does it have? Okay. And it's also secondary associated to ipsilateral maxillary or rhizomatoid sinus infection. So if there is any maxillary or rhizomatoid sinus infections, they can travel into the frontal sinus. All right. So these are the etiologies: viral infections, swimming, fracture, and the penetrating injury causing the fracture, the rupture of the sinuses or inflammation of sinuses, edema of the middle meatus, and infection of the maxillary sinuses or ethmoidal sinus. Okay. Now, coming to the clinical features part, it's in the frontal sinus. So the patient will have frontal headache, very local headache they will have, very localized. They will tell you that we have pain only here. Okay. So it is usually very, very severe pain because it is inflammation of the sinuses within the within the skull. It shows, it becomes periodic sometimes, and it comes up on waking, or it increases in size, it peaks. Okay, it progresses the intensity of the pain. It comes to peak on the midday and then stops subsiding in the night. It is usually also known as office headache because in the midday the patients are in the offices, right? So they tell you that I get headache, frontal headache only when I'm in office because of its presence only during the office hours. It is also known as office headache. Also known as, all right. So frontal headache, very localized, peaks up in the midday, then it subsides down. This is pain intensity. Okay. Apart from this, the patient will have tenderness. So pressure upwards on the floor of frontal sinuses causes pain. It will be tender. Okay. And even if you tap the frontal part of the bone or the anterior wall of the frontal sinuses, these patients will complain of pain. Other than that, we have something called edema of the upper eyelid. This is because of conjunctiva and photophobia. So these patients will complain of photophobia and conjunctiva. More towards it looks like migraine. But then migraine is never frontal. It's a throbbing severe pain, right? It's just not localized. It's not, you don't feel tenderness in the migraine headache. Okay. And over the period of time, it can also cause nasal discharge. So what is nasal discharge? It is a vertical streak of mucus high up in the anterior part of the middle meatus. So this is nose is lateral part. We have three meatus. So here you will see mucopus. Okay, this may be absent if the ostium is closed, but if the ostium is open, the patients will have nasal discharge. But usually there will not be any nasal discharge. That's why the pain will be more severe. So acute frontal sinus will have frontal headache, will have tenderness over the frontal part of the skull, edema of the eyelid, along with photophobia, and they might have nasal discharge if the ostium is closed, there is no discharge. Nasal discharge if ostium is open. All right. Now, how do you diagnose this patient? I did not write diagnosis because there is only one key way. You can also do an X-ray, but sometimes it might not show up in X-ray. It might show opacity of the affected sinuses or fluid levels in the affected sinuses, but sometimes it might not show. So CT scan is the most preferred modality. So anytime when a ENT physician wants to, uh, confirm any diagnosis, he will just do CT scan of the skull. Okay. So CT scan is the best. Treatment, as I told you, divided into two. Medical and surgical. Now, medical here means conservative method. So this is same as of acute maxillary sinusitis. So so every sinus can get inflamed. Maxillary sinus can get infected. Frontal sinus can get infected, or what do you say? Frontal sinus, maxillary sinus can get infected, or ethmoidal sinuses can get infected. So here, what you do is you give an antimicrobials. You give them decongestants decongestants to uh, release the condition in the ostium for drainage and analgesia. So some patients might not have an open ostium, so they will not have any discharge. So what you do, you give an decongestant. So this decongestant will cause drainage. You give them painkillers, analgesics. You give them a combination of antihistaminic with other oral nasal decongestants. Okay. Nasal decongestants drop, analgesics, provide them steam inhalation, or you give them hot fermentation, anything. But make sure that, you treat the patient conservatively. Now, there is another way where you place a cotton soaked in vasoconstrictor in the middle meatus once or twice a day. This helps to relieve the edema and promote sinus drainage and ventilation. Okay. So, the other way is that you place a cotton soaked in a vasoconstrictor in the middle meatus. I'll write it down. Soaked cotton in vasoconstrictor. BID. Okay, it's 2 times a day. Okay? Okay. Now, if this doesn't work, conservative treatment doesn't work, then you go for surgical treatment. So surgical procedure is known as trephiniation of frontal sinus. Of frontal sinus. So what happens here is that if the patient does not get managed by conservative treatments, he is not relieved of his pain, he is having fever, even after continuing conservative management for more than 2 days, he has lid swelling, eye swelling, uh, but there is higher chances that he might have orbital cellulitis. So you drain the frontal sinus externally. So what you do, you make a 2 centimeter long horizontal incision in the superior medial aspect of the orbit. So this is your orbit. Superiorly, medial. Superior medial aspect of the orbit below the eyebrow, you make a 2 centimeter incision. Now what you do is that you explore the floor of frontal sinus and you make a hole. You drill a hole with a burr. Okay. What will happen? You will see pus. You take the pus for culture and sensitivity, and then you place a plastic tube so that it drains off any remaining pus. Okay. So you make a 2 centimeter long horizontal incision in the superior medial aspect of the orbit. You see pus, take the pus for culture and sensitivity, and then place a tube. Now, sinuses here will start to irrigate with, drain off. And you irrigate it with normal saline. 2 to 3 times in a day is more than enough. So this can be determined by adding few drops of methylene blue to the fluid to see if it is exiting or not. So if you see here, you're making an incision, right? And then in the end, they place a tube. You remove this tube when frontal nasal duct becomes patent. Remove when duct becomes patent. Okay. So this is trephiniation of frontal sinus. Now this acute frontal sinus can have complications as well. Uh, Write it down here. Because of its close proximity with eye, it leads to orbital cellulitis. Okay? Can cause osteomyelitis of the frontal bone. I'll just write osteomyelitis. Understand it is not osteomyelitis in the whole entire body. It is osteomyelitis of the frontal bone. Can also lead to meningitis. If the infection breaks through the posterior wall of sinuses, it can lead to meningitis or extradural abscesses. Can complicate into meningitis. Okay? Or frontal sinusitis. If acute is not treated or neglected, if not treated properly, it can complicate into chronic frontal sinusitis. I hope acute frontal sinus is very clear. Now, let's move to the next topic, that is nasal bone fracture. So, trauma to the face is when the injuries of the face can involve soft tissues. So, what are the soft tissues that you have in your face? You have parotid gland, you have tongue, you have eyeball, right? You have glands. So, all these are soft tissues. Or it can lead to directly fracture of the bones, right? Or both. So majority of the facial injuries are because of automobile accidents, car accidents, RTAs we say. Sports, personal accidents, assaults, fights, all these things can cause trauma to the face. So how do you divide it? How do you divide the management? You divide the management into general management. If there is any soft tissue injury, you have to make sure you treat the soft tissue injury. If there is any bone injury, then you make sure you treat the bone injury. Okay. So when a patient with facial trauma comes to the hospital, you have to first rule out. After general management, of course, you'll have to rule out if it is a soft tissue injury or bone injury or it's both. Okay. What comes under general management is what I want to tell to the FMGs. The general management to trauma of the face is important. If you're going to write any steps or any exams that you should know, any facial trauma should be managed by airway breathing circulation, ABC. Airway, maintenance of the airway, that is the first priority that you should give to the patient with facial injuries, or you have to check if he has aspired any foreign body or there is blood, and you have to secure his airway. Second is that the facial injuries can bleed heavily. All right, so it can disrupt breathing. So injuries to the face may bleed profusely and they might be stopped by pressure or ligation of the vessel. That is the second priority, or else the patient will land into hemorrhagic shock. Okay. And then you treat the associated injuries like head, chest, abdomen, neck, larynx, cervical spine, or whatever. Make sure you stabilize the patient uh, cervical spine when he has an accident. All right. So coming to the topic that we have, which is more important for us to talk about, is the nasal fractures or nasal bone fractures. There are two types. One is depressed and one is angulated. Depressed, they are due to frontal blow. So if you're standing in front and someone punches directly in front of your nose, on your nose, you have a depressed bone fracture. So the lower part of the nasal bones are thinner and these will easily give away. Okay, these parts are very thin bones. So any severe frontal blow will cause an open brook fracture. So we say an open brook fracture. Okay, what happens here is that the nasal septum gets collapsed and the nasal bones will just spread out. So they will splay out. Nasal septum will get collapsed and all the small nasal bones will splay out. Okay. The greater the force, the more severe is the injury. So if the force is more severe, it can lead to even comminution of the nasal bones and also fracture of the maxilla with flattening of the nasal dorsum. So this becomes flat, like this, if it is very severe. So maxilla, if it gets fractured, it can cause more severe, you know, uh, fracture. Coming to the next point, next type that we have, angulated type. So angulated lateral side, lateral blow. That may cause either unilateral or bilateral. Since it's on one side, it usually causes unilateral, but if it is very severe, it can damage both the sides. If you punch it like this, it will just go bilaterally. Okay. Now, nasal fractures are often accompanied by the injuries of nasal septum 90% of the time. Okay. It can be dislocated or it can be fractured into several pieces. You have to make sure that you prevent septal hematoma in a patient who is having nasal fracture, because septal hematoma can grow in size very swiftly, and what will happen is that it will compromise the patient's breathing, can also lead to hemorrhage. All right. So make sure that angulated patients, usually they will have septal hematoma. You have to make sure that, you just uh, manage the patient accurately to prevent septal hematoma. Coming to the clinical features, the patients, of course, there will be swelling of the nose within few hours. Abruptly, there will be swelling of the nose. There will also be periorbital ecchymiosis, where there will be bruise around the orbits. Now, this is a red flag. It can cause increased intracranial pressure, and the patient might even land into coma. So you have to take seriously the periorbital echomycosis. All right. Or there will be tenderness, and there will be tenderness. Of course, there will be nasal deformity. Nose might be depressed, depends on the way of fracture, how severe it is. It can be in different shapes and forms. Usually, the nose may be depressed from front or side, or the whole nasal pyramid is deviated to one side if it is a lateral blow, angulated blow. The whole nasal the septum will be deviated. If the fracture is very severe in the nose, what happens is that there will be creps. So if you touch the patient's nose, you will literally feel the crepitus of the bones, because the bones are all into crusts and pieces. So when you touch it, you will literally feel the crepitus. Of course, the patients will have epistaxis, because of which artery is the main artery which causes little saline? Sphenopalatine artery, right? Now, nasal obstruction because of septal injury or hematoma. All right. So that's why you have to make sure that anyone who's having a nasal fracture, you have to prevent septal hematoma from setting in. Now, lacerations of the skin, of course, if the injury is because of some sharp or a blunt object, it can tear off the skin and cause nasal skin laceration as well. Now, if you see here in the diagram, you see that the patient's nose is deviated from here. There is deviated nasal septum. And you can see the cartilage is torn. This part of the nose has very thin bones. So this is very easy to get fractured. All right. Now moving to this diagram that we have, this one, it's in your respective books, which will show that there is nasal septum deviation. There is fracture in different ways. If you see, the nasal septum is fractured from here or from here, and then the lateral bones from here, right? So A is normal, B is frontal blow, causing depressed fracture. We say as open book fracture. If you see, this is open book fracture. You have to draw this diagram in your examinations. Okay, and C is lateral blow on the side, causing nasal septum deviation or fracture of the nasal septum. Anything. All right, how do you treat these patients? Before that, how do you diagnose it? X-rays are not relevant. Okay, X-rays should only include the right and the left lateral views. The diagnosis is done only by physical examinations. X-ray sometimes may show or may not show fracture. So patient should not be dismissed saying that, you don't have fracture if you don't see it in an X-ray. Physical examination in the nasal fracture is more important compared to the diagnostic tool. So don't rely on the diagnostic tool for a nasal septal fracture diagnosis. Physical examination is enough to rule out if the patient is having nasal fracture or not. All right. Now coming to the treatment part, simple fractures without any displacement should not be treated. Okay, there's no requirement of any treatment if it is a simple fracture. It will heal by itself. And if there is any edema, what you can do is you can give them analgesics and you can relieve it. The best time to reduce a fracture is before the appearance of edema. Now, how will you do that? If there is an edema, you give them NSAIDs, right? You don't treat simple fractures. You treat fractures of nasal septum before the appearance of edema or after it has subsided. Now, sometimes some patients will come with edema, right? So what you do is you don't have to do an emergency surgery. What you do is that you wait for 5 to 7 days, give them analgesics, wait for 5 to 7 days. When the edema subsides, then you decide if you have to do a close reduction or an open reduction. It is difficult to reduce a nasal fracture after 2 weeks. So it should be 5 to 7 days. Okay. Usually nasal fractures will heal by itself within 2 weeks. That's a half a month, 15 days. But if patient comes before 15 days, wait for 5 to 7 days. If there is edema, if there's no edema and you think the patient needs surgery, then get a surgery done. 2 ways to do the surgery: close reduction and open reduction. Close reduction is when the depressed fracture of the nasal bones uh, either are sustained from the frontal or the lateral blow. So even the frontal blow causes depressed fractures, and the lateral blow can also cause the depressed fracture. So laterally, what you do is the displaced nasal bridge can be reduced by firm digital pressure in the opposite direction. So someone punched you from the right side. Okay, your nose is deviated to the left. So what you do is that you put a firm digital pressure in the opposite direction to fix it. Okay, so impacted fragments sometimes require disimpaction. If it is impacted, you will have to rearrange them and then you have to align them in place. So septal fractures are also reduced by a procedure called as axe forceps. You don't have to dive deep into the topic of what is axe forceps and all. But then you should know that you have to make sure that septal hematoma, if present, must be drained in these patients who are having close reduction. Okay. Again, simple fractures may not require any treatment. Unstable fractures will require intranasal packing, and you give them external splintage. You give them a nasal splintage, and then you wait for the edema, if any, to subside for 5 to 7 days, and then you do close reduction by your digits using your fingers. You know, other than that, we have open reduction method, wherein early open reduction in nasal fractures are very rarely required. Okay. This is when the close reduction fails, you go for an open reduction. So septal injuries are better reduced by open methods. So what you do is that you do a rhinoplasty or a septorhinoplasty. The procedures that we do now for cosmetic appearance, to make the nose thinner or to make the nose a bit smaller or to just cut off the top of the bone and make it look clean, right? So those procedures were actually used for the patients who had nasal deformities due to RTAs back then. But then now they are more commonly and frequently used for cosmetic appearance, according to the wish. All right. So we have open reduction where you do a rhinoplasty or septorhinoplasty. Okay. Or you have a close reduction where you wait for the edema to subside, if any, and you do it before 2 weeks, because after 2 weeks, the nasal bones will start to heal by themselves. All right. Coming to the next topic that we have is fractures of maxilla. So what are fractures of maxilla? Maxilla is this part, right? So it is divided into three types. It's classified into three types. Knee 41, Knee 42, and Knee 43. This is very, very important for FMGs as well. And especially for ones who are doing specialties and all, they will always ask you the fractures of maxilla. So Knee 41 is the fracture that runs above and parallel to the palate. Okay? Above and parallel to the palate, like this. And it crosses the lower part of the nasal septum. So this is nasal septum, so it will cross over the nasal septum. The easiest diagram that I can draw, let's say this is nasal septum. This is Knee 41. Knee 41, transverse fracture. Okay, Knee 42, in exam, you just don't have to mention the name. You have to explain what is going on with the fracture. Knee 42 is pyramidal type fracture, like this. Okay, so the fracture passes through the root of the nose, the lacrimal bone, the floor of the orbit. This is the floor of the orbit, the upper part of the maxillary sinus, and the pterygoid plate. Okay, usually will involve zygomatic fractures. These are zygomatic bones, so it can also involve zygomatic fractures. Now coming to the third type, it is Knee 43, where there is craniofacial dysfunctioning. There is a complete separation of the facial bones from the cranial bones. Okay, it can be like this. Anyway, so these fractures line will pass through the root of the nose, can involve the ethmoidal frontal junction, superior orbital fissure, the lateral wall of the orbit, frontozygomatic bone, temporozygomatic sutures. It can cause entire displacement of the facial bone. Clinical features, of course, there will be malocclusion of teeth with anterior open bite. So when they open their mouth to bite, their what do you say, the upper part of the jaw will move forward, anterior open bite. So when you bite, your upper set of tooth will should teeth should sit on the lower set of teeth, but that doesn't happen after once you have a maxillary fracture. You will have an anterior open bite. So when you bite, the upper part of the teeth will just displace a little bit forward, or there will be elongation of the mid face. So this is the mid face. It will be a little bit elongated, especially this part, because the maxilla is fractured. So it will be elongated a little bit. Or you will see there will be mobility of the maxilla. These patients can also have CSF rhinorrhea. Now, CSF rhinorrhea is when your CSF starts to flow down from your nose. You have to be very careful. You might think that it's just a nasal discharge that the patient is having. No, that will be CSF rhinorrhea. That means the CSF fluid is leaking out from the nose. This is because of cibriform plate is injured in the Knee 42, and sometimes it is seen in Knee 42, but most commonly seen in Knee 43 fracture. Okay. So cibriform plate damage can lead to CSF rhinorrhea. The base of the skull will get damaged, leading to drainage of CSF fluid down there. Diagnosis: X-rays can help. CTs are mostly preferred. Okay, they help to delineate fracture lines and displacement of fragments. X-rays are helpful, but CTs are preferred. How do you treat these patients? How do you treat patients with fractures of maxilla? It is complex surgery. Usually we need, maxillofacial surgeons, and you have to maintain the airway breathing and circulation of the patient. If there is hemorrhage, you have to stop the hemorrhage. Usually it happens from the maxillary artery or its branches. Okay, and then you have to make sure that you don't deform the patient's face. Already it is deformed. So you have to make sure as a surgeon, you have to give them a good cosmetic appearance. Okay. And every fracture, facial fracture, should be treated early when the patient permits. Of course, without patient's consent, you do not have to even touch the patient. So fixation of maxillary sinuses can be achieved by intradental wiring. Okay, you can use a help. You can help take a help of a dentist, and you can do an intradental wiring, or you do an intermaxillary wiring using arches and bars. Place bars inside, all everything inside. Open reduction, you open up the mouth, and interosseous wiring, you give it in the zygomatic fractures. Okay, all these are done by wires and slings. Okay, wires and slings from frontal bone or zygoma or infraorbital. So you use wires to bring down everything to place. Okay, so these are the fractures of maxilla. For type 1, 2, and 3. This is pyramidal shape, type 2. Type 3s are involving the base of the orbit, the nasal septum, the root of the nose, and the entire maxilla along with zygomatic bones, if you can see. Okay. Coming to the next topic, what is orointral fistula? So orointral fistula is communication. So what is fistula? Fistula is communication between two structures. Okay, anything can cause lead to fistula. So it is oroantral fistula is the communication between the antrum and the oral cavity. Okay, so the opening may be situated on the alveolus or on the gingivolabial sulcus. So this is how it will look, fistula formation, like a part, like a hole, like a drill, like a pathway. Okay, so what actually happens here is that usually seen in after dental extraction. So it is a complication. Oroantral fistula is not in itself a disease, but it is a complication, usually seen after dental extractions because the dentists use, anesthetic injections to inject to block a nerve. So they usually inject it in your gum or the palate. Sometimes some patients are not lucky enough and they might form fistula. So that is oroantral fistula. So dental extractions are the most important and the most common causes that leads to oroantral fistula. So the roots of second premolar or upper molars, which are very closely related to the antral cavity, and their extractions can lead to fistula formation. If you can see, okay, second molar or upper molars are very closely related to the antral cavity, so it can lead to oroantral fistula. Apart from that is failure of sublabial incision. Sometimes it is failure of the incision to heal after the specific operations or surgeries, or if there is any sort of carcinoma, or there is fracture of the maxilla itself, or there is osteitis of maxilla. Conditions like syphilis and malignant granuloma might also cause oroantral fistula, Okay. So here are the etiologies. Coming to the clinical features, these patients will have regurgitation of the food. They eat food, the food gets stuck into that hole and it might regurgitate. The food or fluids may pass from the oral cavity into the atrium and then it comes out from the nose. If it is connecting to the nose, it will come out from the nose. Or there is discharge. Atrium is always infected. All right. So foul smelling discharge these patients will have either from their nose or from their mouths because of the food, retained food that has caused infection and many other reasons. Or sometimes it is inability to build positive or negative pressure in the mouth. If you ask this patient to hold some air in the mouth, like they won't be able to do it. Why? Because the air is just passing through the fistula and coming out from the nose. So patients will have difficulty to blow the wind instruments or drink from the straw or drink through a straw, or they will not be able to create pressure in the oral cavity. All right, this is because of the fistula. The air gets in the fistula from the nose or to the antrum to the oral cavity. Okay, so it is always the oroantral fistula that might lead to these type of defects. Diagnosis is usually done by a probe, which you pass it from the fistula opening into the oral cavity and you see where it ends. Okay, no CT scan, no X-ray. You just take a probe, you put it in the fistula and you see where it is ending. Is it coming out or not? Treatment, if there is recent fistula, discovered immediately after tooth extraction, and then there is no infection or any retained tooth, you treat it conservatively by giving them antibiotics. Other than if someone is having chronic fistula or very large fistula, these patients will require surgical replay. But what you do is you do a palatal or a buccal flap. Okay, so first you treat maxillary sinusitis because that is 90% of the patients with orointral fistula will have maxillary sinusitis because fistulas are always infected. Any fistula will always be infected. So you have to make sure that you treat maxillary sinus by giving them repeated irrigations and antibiotics. After that, you track the fistula, squamous line fistula, you track it, you excise it, you see the bone edges of the fistula, and if it is eroded, you smoothen it and you prepare the flaps to sit properly on that bone. Okay, some procedures might require Caldwell Luke operation to remove the retained tooth or any foreign body, if any. Okay, so you have to treat according to the recent fistula and chronic fistula. Recent, no symptoms discovered immediately without any infection, give them antibiotics. Chronic, make sure you heal the maxillary sinusitis first, do irrigations, give them antibiotics, and then take them for surgeries. When you do a surgery, track the fistula, excise whatever is eroded or necrosed, smoothen the edges of the bone, and then create flaps over it to sit properly. So this is how it will look. If you can see, this patient had this tooth extracted, and the fistula is somewhere here close to it. Okay, so this is orointral fistula. If you can see here also, we have an orbital margin. This is the lip of the patient. This is orointral fistula, somewhere here in the gum. Here. Can happen here, can happen here, anywhere in the mouth. Orointral fistula, somewhere near the antrum. Okay. So I think we have covered the major topics for today. Bone fractures, orointral fistula, and acute frontal sinusitis. All these are important. Please make sure you remember all the three types of maxillary bone fractures. Important. Thanks for watching.